Hello, everyone. I'd like to welcome the over 200 people who have registered for this webinar today. Thank you for joining us. My name is Annette Brown, and I am one of the co-leads of CRiHHI Healthcare, a research program focused on mitigating health and healthcare inequities in a range of contexts and settings. As this webinar proceeds, questions for the presenters can be submitted via the Q&A function at the bottom of your screens, which will be monitored throughout. Your questions will be used as the basis for the Q&A session that follows our two presenters. We are broadcasting today's presentation from the UBC School of Nursing in Vancouver, which is located on the traditional, ancestral, occupied and unceded territories of the Musqueam First Nation. I'd like to begin the webinar by providing opening remarks and a land acknowledgement pre-recorded by Dr. Elder Roberta Price. Elder Roberta has been highly influential in shaping the underpinnings of the research program known as CRiHHI Healthcare. Please join me in viewing her welcoming remarks. Cheyenne, please play the video.
CRiHHI OCM, greetings and welcome everyone. I want to share a teaching to start us off in a good way. I have in my hand a cedar headband. I'm going to place it on my head. I have around my neck a cedar necklace. And as taught to me by my elders, that when we put on parts of our regalia and we carry our sacred items, we're given an indication to our ancestors and the Creator that we're going to share in ceremony. So thank you everyone for listening. I'll start us off now in a good way. CRiHHI CM greetings and welcome everyone. As Coast Salish matriarch and elder, I wish to give a very warm thank you to all my relatives on the Musqueam, the Squamish, and the Tsleil-Waututh for welcoming me to live in the unceded lands of my relatives, Musqueam and Richmond, for 40 years now. As Coast Salish matriarch and elder, I wish to give each and every one a very warm welcome who live, work, and play, give and receive service, teach and learn on our ancestral, unceded, and occupied lands of my relatives, Musqueam, Squamish, Tsleil-Waututh. For each and every one of you out in this very wide virtual circle we're in, the teachings I'd like to offer to you is to take time each week or each day to have reflection and give the honor and thanks to all the ancestors of the lands on which you live, work, and play on, give and receive service, teach and learn on. Thank you for listening. OCM.
Thank you to Elder Roberta for arranging for us to view her welcoming video. I would next like to introduce our two guests. Gord Garner is Vice President of Strategic Partnerships at the Community Addictions Peer Support Association, also known as CAPSA. And Dr. Alexander Caudarella is CEO of the Canadian Centre on Substance Use and Addiction, known as CCSA. We will hear from Gord first, then from Alexander. Following both presenters, we will have a Q&A session. This portion of the webinar will run from now until 1 o'clock Pacific Standard Time. And at 1 p.m. Pacific Standard Time, we realize that many of you will need to sign off. For those of you who wish to stay on for the optional Q&A, please remain on the webinar. The optional Q&A will run from 1 until 1:30 Pacific Standard Time. And with that, please, Gord, I'd like to invite you to begin.
Thanks very much, Annette. It's good to be here together today. I want to begin by just recognizing that stigma affects us all, and it's often in a way that people have become so accustomed to it that it has become normalized. If we can go to the next slide now. It's founded upon, it's best understood as a deeply held set of false beliefs about a group of people with at least one attribute in common. And this false belief allows the judgment, oppression, and discrimination of those people to take place. This is done either by overt actions or silent compliance to those actions. And often when we're looking at systemic issues, we're looking at things that, again, have become customary and normalized, but are deeply seated in this idea of a false belief. And so let's take a look at some of that stuff as we go through the slides together. So first, we want to start off with the idea and knowledge that 78% of people living in Canada over 15 will be using substances this year. And so this is why it affects us all, because if we aren't ourselves using substances, we certainly know someone who's using substances, someone who chooses not to use substances, someone whose health choices not to use substance belief systems. But all those people need support around their health around this issue. Next slide, please. The closer look at the numbers, this is a report, 45 billion annually in Canada. And of course, we think of those immediately in terms of healthcare costs, but actually most of the costs come from lost productivity. We're not looking at costs of a healthcare system, we're looking at costs, social costs impacted. And out of the Canadian survey, less than 9% of respondents said that their doctor spoke to them about their alcohol use. So obviously there's a gap here between understanding what's going on, what our social issues are, what our health cost issues are, what the impact on the community and families is versus the services and the conversations we're having around substance use health. Next slide, please. This is from the US. And again, we're recognizing that most of the healthcare costs and social costs and productivity costs lie within that vast majority of people who simply use substances and do not have a substance use disorder, but do not have any information or any sources of knowledge or decision-making supports around that, what has become normalized use. Next slide, please. And that's again, just in the chart, so you can see on the left-hand side. And again, when you look at lost productivity, it kind of speaks to that stigma of the assumption that people that are impacted by substance use are experiencing homelessness and poverty at the same time. The majority of people using substances remain active in the workforce, and yet without a doorway to have a conversation about their substance use. Next slide, please. So you get a system that's built around some false beliefs, and you get primary care providers who don't talk about substance use and health. There's the assumption that unless you have quotation marks an addiction to substance use disorder, then there is no help for you. And even then, because of stigma, no one wants to have those things. And so self-diagnosis becomes the key. And the crisis point becomes the entry point into the healthcare system for people struggling with substance use. Again, recognizing many people aren't aware of their health struggles with substance use, they're merely using substances in a way that has become normalized for them without information. Because of this splintered system, many people arrive at the door to be told that they don't serve people like you here, because there's a pre-screening process built around the success of the organization and the services they can provide for the specific targeted populations they serve. And so it's almost like a reverse triage system where people get triaged out of services for the inability to be successful within those services. Multiple weight systems, it's all based on this concept of that. The perceptions, again, inequitable, no funding, self-perpetuating, because you have to report success, so you can't bring in people that you don't think will be successful in your system. So by far, the majority of people with issues never get in the system. In fact, we know something like 9 out of 10 people never get to the doorway. And part of that is that invisible barrier to others, the fact that they simply can't go and have a conversation about their substance use. Next slide, please. Health Canada struck an expert task force, which CAPSA was privileged to have a person attend, and made some recommendations to federal government's drug policy. And it talked about removing structural stigma and center on the health of people who use substances and align with current evidences. And so that's what we've been talking about for a number of years. Again, there's that experiential knowledge of people trying to access the healthcare system, where stigma and discrimination is quite easily seen by us, but people acting within the system actually don't recognize that. That mental health and addiction story has become so cemented into people's minds, they don't hear how crushing the end addictions is. how silencing it is around all the other conversations of health related to substances. It is just the sign on the door. Next slide, please. Social determinants of health, historical harms, and persistent intergenerational effects. Struggles don't come from nowhere typically. And of course, the need to describe the impact of inadequate regulation of pharmaceuticals, tobacco, alcohol, cannabis, illegal substances. It's hard to coach anybody around substance health if you don't know what they're taking or what the quantity is or the strength of dose that they're taking. It's very hard to manage your health in ignorance. Next slide, please. So there was a suggested an integrated approach was take place. We placed the four pillars of the Canadian drug strategy and talk about how it's all interconnected, articulate harm reduction as effective evidence-based non-judgmental public health approach, and include a full continuum of harm reduction treatment and recovery care services. Next slide. CAPSA presented to the expert task force on its substance use health concept, its vision to create equity for substance use health resources and funding advanced equitable care across the spectrum of health around substance use. Understanding that mental health and physical health do not presume illness or strength-based languages, and so why aren't we using the strength-based language when it comes to substance use health? You know, and as you know, with physical health and mental health, we have developed more and more outside resources in terms of supporting people's wellness throughout their lifetime, including things like walking trails, running trails. That's all around supporting physical health without any presumption of illness. It just makes sense. Next slide, please. So we see this really as something that's encircled. We know that equitable societies, they may be hard to find, but the more equitable they are, the greater physical, mental, and substance use health they experience. We know that coming out of that, you're going to need education around what that looks like. Why should it be that when someone's experiencing a health issue that no one knows or anything about what that is or is able to talk to them about it? Supports for increased health across the continuum of use, and then supported regulations, which basically means the concept is that you would know what you had in your hand and what was the impact would be if you're going to use it, and you would know where that was and who's available to and who it's not available to in a very real way. Next slide, please. So here's the spectrum. No use. Again, we want that to be an informed, knowledgeable decision. And without facing stigma. We're just finishing a small research project with CCSA and Carleton University on students experiencing stigma for not using substances on campus and what that feels like, the social exclusion and level of loneliness they experience because of that. Beneficial use, lower risk, problems occurring, and the substance use disorder. Recognizing that that's a spectrum and it's not a continuum. You don't just start there and you're going to go somewhere. You can be in multiple places, even at the same time with different substances. And so it's not difficult, but it's complex and it needs to be discussed. Again, we just finished a national survey with the support of CCSA about substance use health, people's knowledge about it and associated services. 78% of people we interviewed, and there was over 2,000, believe substance use health is an urgent issue. 80% think Canadians need more access to information, health services, increased lifelong wellness about substance use. So here's a very quick question. Without the survey, did anybody see any of that in the newspaper anywhere? And so again, we see the silence of the conversation through the anti-addiction language and to just that idea that we can't talk about the subject and we can't use the word health in connection with substance use. In fact, in this survey, 66% of Canadians have never been asked about their substance use by their healthcare provider. Only 26% of Canadians know where to go if they want to change or manage their substance use in some way. Now, this 26%, only 1.2% thought their doctor could help them. That's a systemic level problem around the fact that because the doctors never had the conversation, they're not seen as helpful. Why haven't they had the conversation? Education, training, comfort level, the anti-addictions door speaks to what they get educated on, speaks to the comfort level, speaks to the inability or belief that they can't be of help and therefore they're seen as not being of help. That's systemic stigma at its worst. Next slide. 75% have never received any direct support for their substance use from the healthcare provider, education, advice, strategies, or they didn't think they needed to be asked. even though 78% of people living in Canada use substances. And why don't people think they need to be asked about their subuse? 76% believe they personally have enough information to make informed decisions. Going back to the fact that 49% reported they got that from the media. So I'm not sure about you folks, but I'm pretty sure the media isn't my source of education, because it's not where we learn about most of all the issues from, although it can inform us in many ways. Next slide, please. Again, got this up here twice because you need to understand that this comes from this deeply held set of false beliefs. The false belief is that either you're bad, you don't know how to use substances properly, or you're good and you're therefore healthy. The system's designed around that false belief, and the system's designed around the idea that you're responsible. Let's take a look at the next slide. As a result of the lack of education of people in Canada around using substances, 25% still believe that addiction is a choice. Unless you have an addiction, you're healthy. Next slide. So the bottom line, the need for a health promotion approach to subuse within a spectrum of services along a spectrum of uses could not be clearer. We need to do better with each other. We have a right to know. We have a right to make decisions. And I just want to touch base, if I can, for a second. Knowing there's risk involved doesn't mean I'm not going to take the risk. I just flew here on Sunday, and on the plane, I said to somebody, you know, it's less risky up here than it is driving the car to the airport. I know those things. And yet I drove the car to the airport and I got on the plane. We're not all going to stop using substances. That's not what anybody's talking about. We're talking about using substances in an informed way so that I can make cost-benefit decisions for myself in a clear way. Next slide, please. And we see this language of substance use services, and I just want to be clear on what those are. Beer in liquor stores, Canada shops, illicit drug dealers, licensed bar and restaurants, alcohol home delivery. Those are substance use services. So this language is starting to get involved in our healthcare system, but that's not what our healthcare system is. Next slide, please. Because we don't talk about mental services. We don't talk about physical services. So why do we say substance use services when we're actually talking about healthcare services? Next slide. That's because of stigma. The simple inability of the healthcare system to attach the word health to substance use. And so you see all these are substance use health services. That's what people are actually talking about. So let's use the right language. Let's not confuse substance use services with substance use health services. Again, it's just another systemic stigma block to people accessing these services. Next slide. Well, I think it's time for me to say goodbye. My time is up. And so we'll leave on the substance health notice, and the change begins with me. And of course, I'm hoping the change will continue with you. Thanks for your time and attention.
Thank you very much, Gord. Next, we have Alexander, who will be guiding us through the next part of the presentation. Thank you.
Thank you very much. So CCSA has been really fortunate to work with CAPS on a number of things. I think being able to embrace and move forward with a health first and a strength-based approach is one that's really important. So I'm gonna talk a little bit of some of the setting, and then I know certainly our most recent alcohol guidance has been of interest for a lot of people. So we're going to talk a little bit about how that lens applies for this. Next slide. Just to say that other than funding from the Government of Canada and my employment at CCSA, I have no conflicts. I'm also an employee at a hospital in Unity Health Toronto. Next. This is CCSA's land acknowledgement for where our offices are based. And I very much appreciated the acknowledgement that was done at the beginning of the session today. Next slide. For those of you who aren't familiar, this organization, we were created by an act of parliament in 1988 as a non-governmental organization to provide national leadership on substance use and to advance solutions to address alcohol and other related harms. Next slide. This is a bad time to be a person who uses drugs or alcohol for a number of reasons. And as Mr. Garner has told us, it's 78% of people. So it's just not a very good time for a bunch of reasons. But the flip side of that is, next slide, there's actually never been more options in terms of the breadth of either treatments or supports that could be offered to people who might feel that they need help. The problem is people don't have access to it, and there's not enough of them available, but there's a strong evidence base for more things than there have ever been around issues of substance use health. And these are just some of them that are listed here. Next slide. So all those things have something in common, and as was just pointed out, most of them, the way you get into them, what you do, they all focus on illness or something wrong rather than a strength-based or health-based approach. This is actually a book. This is an author who was an Indigenous scholar who'd written a best-selling book called Firewater. And this is a book actually Mr. Garner kindly asked me to read. So he gave me a copy of it, and I had it around the house. And this is a really interesting book if anyone wants to read. It's about it's fiction and a memoir at the same time, and it's about his personal experiences and all the kind of things that go with it. But what was interesting is, so this book, my son, who's 3, picked it up in our house, and he can't read because he's 3. So he picked it up and he said, "This is a book about fixing chairs and making chairs fantastic." And I just thought that that is no way how an adult would look at this book. And it just struck to me how intuitive the experience is for young people, and I think for human beings, to look at things through a strength-based and in many ways a health-based lens first. And it's kind of beaten out of us. For any of you, I'm a family doc, so for any of you who are in the healthcare system, it's kind of beaten out of you as time goes on. But I think it's really important to recognize that it's actually a fairly intuitive way of looking at things. Now, the actual story of the 3 legs of the chair is really interesting if anybody's going to read the book. But there's just this idea that focusing on strength is actually a very natural position. And so it's very odd that our system doesn't. Next slide. And so we kind of end up in this system where you live, who you meet, is going to control the kind of care you receive around the substance use issues you may have. Almost all of it is on demand. And although it's good for people to be able to reach out, on demand in this context means people knowing exactly what they need and then going out and seeking out that thing. And heaven forbid if you have any kind of significant physical or mental health issues in terms of trying to access any actual resources around this. Now, what we heard was, we don't want to serve you. You heard that in the last lecture. But it's more nuanced than that most of the time. We create environments that are intentionally or sometimes unconsciously problematic for people who might use drugs or alcohol. We create emergency rooms that are full of bright lights and noises. We ask questions in a rapid fire way, all things that would be really difficult for anybody who consumes or is in withdrawal or intoxicated in some way. And we have really great ways in the healthcare system of labeling charts as somebody left the emergency room without being seen, or left the hospital, as we call, against medical advice, which are all just symptoms of us being unable to create systems and environments that support people, but make us really feel better and medically, legally help us cast away some of that. So when we're talking about substance use health services, when we're talking about that, it's going to be really important to think, and I know Equip Health has done a lot of work around trying to make more equitable and more frankly, safe environments for people to receive service. Next slide. I know there's a lot of talk about our healthcare system and the potential privatization of it. And so we have a substance use system that's been two-tier for a long time. And there's the obvious part, which is people who can afford stuff will pay for it. But then there's the less obvious part. And we heard about that in the last one. You have to go through one door if you have an alcohol problem, and complete the other door if you have an opioid issue. And you have to go through one door if you want to quit, and another door if you want to stop, and another door if you have no interest in. And you have to pick all these doors yourself. So we've divided up our system in many, many ways. And for all the people who don't necessarily, as was pointed out, have a substance use disorder, well, we have no doors for those folks to get any health help. Next slide. Really, a lot of, in our mind, providing services for substance use health means asking these two questions. What should happen and whose job is it? And the whose job is it part is actually really important because it's kind of everyone's job. You see, I spent a lot of time working up north in the Arctic, and I worked with people who had no hesitation to crack open somebody's chest if they needed to, even though they were a nurse or a general family physician. But when it came to issues around substance use health, that was not the case. It was somebody else's issue. It was out of scope. It was something else. And these are the underlying issues of stigma that we've heard about that have really forced this into being a specialized area where you go separate from the rest of the healthcare system. And really asking ourselves what good substance use health is means asking ourselves, why in the world can I go everywhere else for all my other health issues, but I can only go into specific doors, addiction doors, substance use doors, if I'm lucky, a mental health and substance use door, but not the primary care door, not the other doors, not the other things for all these health issues. And so in that context, we want to talk a little bit about our new guidance on alcohol and health. Next slide. It used to be low-risk alcohol drinking guidelines, and now it's Canada's guidance on alcohol and health. Some of you may have seen when it was released. Next slide. This is a very, very different way to start looking about how to reduce harm around alcohol and to improve health. We're going to talk a little bit about the nuance of it shortly, but some of it even just starts with the name. Next slide. We received a lot of coverage, and we were really thankful that people were ready to have a discussion around alcohol, but some of it really missed the nuance of it. Next slide. There's one recommendation to reduce the risk of harm from alcohol is recommended for people living in Canada to consider reducing their alcohol use. That they become informed and that they consider reducing their alcohol use. And it takes a lot of things for that to actually be able to come in place. So before, we felt comfortable drawing one line in the sand and telling people that this was an acceptable risk and that they should just put themselves on one side or another. And so taking on a much more nuanced message, next slide, one that really starts to ask people to situate themselves in terms of how much they use, but then also where they want to be, and try and put some of that autonomy back into people's hands. And so there's two really, really important messages that come out of a continuum of risk like this. The first message is, as we heard in the past presentation, you get to decide your risk. We're not going to decide what's safe or not for you. We're asking that you look at this, that you look at our report, that you understand how much risk of different diseases, different illnesses is associated with different people. And then that you go in, you talk to your family, you talk to your people you care about, and more importantly, that you talk to a healthcare provider about how you're going to get where you need to go. And then the second part of a continuum risk that's really important is, instead of drawing one line in the sand, It says any reduction, even if it's small, no matter your age, no matter if you drink so much, you're completely off this, will have a significant and dramatic improvement on your health. And so it's about just little or large shifts from a red into a green zone. And there's some significant implications of that in terms of how you're expected to interact with the healthcare system. Next slide. Just quickly, there's a few other little things. So in addition to the numbers that were there, the other recommendations are people who are going to drink should make sure not to exceed 2 drinks on any day, because there's more harm associated with more than that. Next slide. And around reproductive health, when pregnant or trying to get pregnant, there is no known safe amount of alcohol use. And when breastfeeding, not drinking alcohol is safest. Next slide. You'll notice there's a few things we didn't speak about specifically. There are reviews that were performed and that were done. You can go on our website if you want to look at these specific topics. Next slide. The researchers in a number of these slides, I do have to give credit to the co-chairs, Catherine Paradis and Peter Butt, who co-chaired the scientific panel. I am not that, I am the administrator in this situation. But they did a lot of consultation, soliciting advice from almost 5,000 Canadians. And the most important message was to focus on the facts rather than strict rules or patronizing messages. People wanted to know, and then they wanted to make their own decisions based on it. Next slide. There was a more recent public consultation where 886 people submitted things, both from the general public, professionals, and representatives of organizations. Next slides. So now we talk about the implications. And this is where the substance use health piece becomes really important. It's about individualizing your own risk, but that means being able to walk into any door, walking into your family physician's office, walking into an emergency department, or walking into a specialist in substance use. It means being able to use those environments to have conversations. It means this is everyone's job. It means understanding where your own risk might be. Next slide. It also means re-envisioning what we're talking about when we talk about things like screening and brief intervention. But it also means being more comfortable and knowing more about how to use this. Next slide. I've always liked this framing of harm reduction principles. These 6 big principles in healthcare. And there's 2 that are really important when it comes to the alcohol and when I make an argument around substance use health issues. Pragmatism. It's this idea that no one's going to be able to shoot towards an ideal that you might have. And so embracing substance use health, again, doesn't mean stopping. It doesn't even necessarily mean hitting an arbitrary goal. It means being pragmatic, that any improvements in your health are going to be significant improvements. And we take this anywhere else in healthcare, right? And it's also number 4 is really important, autonomy. Respecting people as informed advocates of their own care and their own health. Next slide. Doesn't mean these things aren't complex. Here's some of the breakdowns, both for females, next slide, and males. You can find these all in our reports that are available on our website, breaking down your increased risk of cancer, various diseases, depending on how much alcohol you consume in a week and in a day. In order to be able to interpret these, in order to be able to make sense of them, in order to be able to take that science and move into a more healthy environment. Next slide. We really have to get back to this. When people are coming in and they either have questions or they feel that they like to do something, what should happen and whose job is it? What you're going to be seeing a lot from CCSA and many other organizations is increasingly not just talking about more services, but talking about the fact that this needs to be everyone's job. If we're really going to reduce harms around alcohol, if we're really going to improve health around alcohol, kind of needs to be everyone's job, no matter what area of health you work in, and even if you work outside health. So this is one of the ways in which we've tried to incorporate some of the substance use health principles and hopefully paint a little bit of a picture. But I think it really begins by recognizing that we don't have systems right now that can support and help people in the ways they need it. And it also requires a lot of introspection. If you're not currently in your role doing something to improve the substance use health of those who you serve, why? Or more importantly, why not? And what can you do? What are the actionable things you can do to make it not so? Thanks. And now I pass it back.
Thank you very much, Alex and Gord. We would like to proceed with the Q&A portion of this webinar. Nancy Lipsky, one of our research managers here at Equip Healthcare, and I will be reading your questions to our two panelists. If you haven't already, we invite you to please post your questions using the Q&A function that is at the bottom of your screen. Nancy, would you like to lead with the first question, please?
Great. So we have a few questions in the chat and I see more coming in. And the first question that we have for the panelists is, what structures, in addition to stigma, impact health professions' ability to adopt a substance use health approach? I think, Gord, I see you leaning in. Would you like to answer this question?
I got caught. I was just going to mute my speaker. I'm going to pause and let maybe Alex, if I can this one over to you, only because I'm not sure what carceral logic is. And so I'll find out about that in a few minutes and get back to there.
Uh-oh. Oh, now we get it. I had known what carceral logic was, and now I've forgotten what carceral logic is. It's slipping my mind. But I will talk a little bit about what structures, in addition to stigma, impact health professionals' ability to adopt a substance use health approach. I'm sure Gord might have some other stuff to add to it. I think that we have created a health system in which people are very comfortable in the boxes in which they work. Roles are really, really important in healthcare. That I get it. They help us make sure that there's competencies that everyone can do. But substance use health issues are really uncomfortable. And so people don't need much of an excuse not to deal with it and not to support people in that. So I think again, it kind of, one of the things is it needs to be explicit about it. So it's not, there is the stigma piece, but I think sometimes people genuinely think it's just not their problem. And so I think more roles are needed to explicitly state that addressing these issues are part of what you're doing, or what you're expected to do, or what you need to do. So again, if we look, for example, back at somebody's in withdrawal, opioids, and they leave the emergency without being seen, we wouldn't traditionally look at that as what we call an iatrogenic harm or harm caused by the healthcare system. But in what way, how can we not look at it that way? So a lot of it has to do with the kinds of things we measure, the kind of accountability we have in place, the usual levers we have for all these pieces. For stigma reasons and for political reasons, for a long time, they just haven't been structured to support substance use health.
No, I will throw in a few thoughts on top of that, Alex, as you suggested. And so we also have a false good story going on that is very convincing and disabling at the same time. We have good folks working at good institutions, doing the best they can and difficult circumstances. And so they know that, right? And people from outside there who come with ideas are seen as people who don't understand. And they're seen as not appreciating the complexity of the system, not understanding that for many years, many of those good folks within that system have tried to get their broken box to work as well as it can, like that three-legged chair, but haven't considered they might need a different chair, you know. And so that idea to get far enough back from it to say, what if we didn't try to change perfectly? What if we just tried to move forward and we wouldn't sacrifice folks on the chair of the impossible idea that somehow we can't change the system unless we do it right? Right. And work in what I call with a sense of urgency, with built-in organization humility to make ongoing changes as you move directionally correct, is at the heart of some of this sort of stuff. And then we don't have to stick to our stories about how we're doing the best we can.
Thank you, Gord. I'll proceed with another comment and question. I will read out the question. It's got some context to it that I'd like you to hear. The question is, I've seen critiques of the new alcohol guidelines that feel that they didn't, sorry, I just lost the place, that feel that they didn't adequately recognize the benefits of alcohol use, which is also an important part of the story when we're talking about risks. It seems to me that recognizing that most drugs have both risks and benefits in variable amounts, depending on the drug and the individual, that is a key piece of destigmatizing substance use and approaching the issue from a truly holistic, strength-based substance use health approach. What are your thoughts on this?
Alex?
You want to start?
Do you mind, Alex?
Sure.
It might be, you know, I'm a little, you know, I'm not sure if anybody knows anymore, but, you know, I had a life of much different from the one I had now. And so I bought and sold a lot of drugs in my life and ran some bars and things. You see, and I've always felt that there's been no problem with the promotion side of substance use. That everybody's done a really good job on that already, because 78% of people over 15 use them. And so we don't really have to worry about adding to the promotion side, but we do need to add into the informed decision side. And we'll let the promoters and the profit makers continue their excellent work. You know, you can't deny the results of their promotion. It's been phenomenal, the uptake of substance use. And so good on them. And then there's other piece that says, you know, so obviously people are enjoying that at some level. So we don't have to worry about that, but we do have to worry about their knowledge, because no one's been working on that. I shouldn't say no one, that's an unkind way. It's been hard to get it publicly awareness, obviously. Thanks.
Yeah, I think Gord answered it really well. One of the first things the scientists did was the number of surveys that found out that very few people were aware of well-established linkages between, for example, alcohol and cancer. Just were not aware at all. And there was a specific question at the beginning of this where the scientists went looking for any known health benefits of drinking certain amounts of alcohol. They could not find a level of alcohol consumption in which someone could anticipate health benefits. Again, it doesn't mean that for everyone the risk outweighs the benefits. It's just to say that specifically in the health context, there is no amount of alcohol that is known to improve your health. And that has been demonstrated very clearly in the literature. Now, it's true that there has been arisen some questions, you know, what about the social benefits, et cetera, et cetera. And again, I think I'm going to point to Gord's point here, because I think you don't need a small agency like ours to tell you what the benefits of alcohol are. There's multi-billion-dollar companies that are very, very, very good at doing that. This is kind of also, I hope I don't get in trouble for saying this, but this is a well-worn industry playbook too. I don't think alcohol and tobacco are the same thing, but you can find a number of academic publications talking about the social benefits of tobacco smoking and how reducing tobacco consumption in our communities will have disastrous social effects. And you can PubMed those, they're all over the place. So I think it's not to diminish. And I think if clinicians are going to go into rooms and make people feel bad about their alcohol consumption, there's a big situation. It's a significant issue. But that's not what we're asking people to do. And it's not what we would suggest is done at all. We suggest that people go in, that they understand what people perceive as the benefits. They help them understand the health effects of the level of consumption in which they're at. And people can decide if for them the pros outweigh the cons.
Thank you, Alex. Nancy, would you like to read out the next question or a selected next question? We have several coming in. Thank you.
So next question for the panelists. What are some examples of effective strategies or methods that help break down stigma towards substance use and people who use substances? Gord, would you like to take that question?
A couple of things, I guess. And it's all advocacy work comes from pain and suffering. And so we know that through civil rights, we know through that through human rights, we know that through women's rights. We've seen that, so this is nothing new, unfortunately. But there are some information, and Bishop, Canadian author, has written a book on the importance of becoming an ally that looks at how to address these things. And I guess the heart of the matter that I would really like to touch on is the change will come from those that are actually causing the harm now. So anytime we do this work, we need to realize we're talking to those who will make the difference. And they may be at this moment in time and space harming us or harming our colleagues, but they are our solution. And if we don't approach them, so not so much so that we can speak, but they can hear, not so much about what is wrong, but what can be right, in a place of engagement and connectivity. And so when we look at this end addictions terminology, and we look at the suggested scorning of individuals suffering not only substance use disorders, but poverty, we're looking at this othering, people live and experience conversation. Well, 78% of people living in Canada using substances. Stop making us so special. Right? Stop separating us. The first thing we have to do is stop them and us. That's always a power dynamic. That's always where you're going to find oppression, is in that separation, you know. And so opening this conversation to substance use health, opening this conversation to realize that stigma impacts us all, that we're not trying to end the oppression of a few. We're trying to increase the health of all of us. And you know, compassionate people are, anyways, I could go on for a bit. So maybe I already have, and I'll be quiet now.
Great. Thank you, Alex. Any particular comments to add?
No, I think Gord's right. The closer you are to this, the less likely you are to have, it's just one of those things. The more people actually start doing the work, start spending time, start talking to people, the more the stigma, in my experience, begins to get eroded. I think also one of the things that's really important is recognizing it's really uncomfortable, and that people are going to be uncomfortable at first, especially. Sometimes stigma can also be a reflection of how distressed we are at seeing that there are people who are suffering great harms, either from a toxic drug supply or a lack of housing or all of these kinds of things. And it is a lot easier, as has been pointed out, to blame people than it is to understand that these are all things that we play some role in some way. So, but I think Gord said it better. So now I'm just babbling on for the sake of it.
Great, thank you. We have time for, I think, a few more questions. There's a question that's asking, how can we get more clinicians to become more comfortable, increasingly comfortable, to talk about the spectrum of substance use health in their everyday clinical practice? I'm wondering, Alex, and then perhaps Gord, if you could address that. Oh, Alex, it's come in another format. Oh, okay. Yes. For sure. Yes. How can we get or encourage clinicians to become more comfortable about talking about substance use health and the spectrum of substance use health in the context of everyday clinical practice?
Maybe some of me cynical, but I think a lot of it comes down to accountability. It has been one of the biggest levers when it comes to clinical practice changes. I think if governments and policymakers and regulatory bodies are serious about it, we kind of have to build it into the accountability. I think if you're somebody who's really interested in doing it, you've probably already started in some way, hopefully. And if not, you know, there are certainly other aspects of it, but if I think we want to see the kind of changes we want, it's about building in measures, indicators that track these kinds of things, and accountability when it comes to the things people see in their training, the knowledge and competencies they need when they graduate, and the standards of care that are expected to be delivered. That's how we've seen virtually anything change. I think that some of the more impactful things I've seen are opportunities for true role modeling when it comes to change and true supervision. This isn't something we're going to get around with weekend courses or one lecture here or there. It is truly about seeing this kind of behavior role modeled well. But then in order to have that, you need more people, for example, in clinical teaching positions who emphasize these things, who support it. In order to do that, you need methods to support the promotion of individuals who are excelling at these skills. I think one of the most important tools is going to be around the expected involvement of lived and living experience in clinical settings. I think if you have individuals who've experienced services involved in the planning, delivery of those services, it becomes very, very hard to look the other way when it comes to provision of those services too. But again, a lot of those things come down to accountability. If attached to funding is an expectation that you're going to have lived and living experience, involvement in your design, implementation, and delivery, then that's really what makes sure it happens.
Thank you. Gord, did you have any particular comments about that as well, please?
Well, I like the word accountability, recognizing that the silence is a lack of accountability. And as we mentioned in our definition on what stigma is, right? Silence and compliance to discriminatory behavior. That's what that is. It's hard to say it out loud even, because that's not how it's thought of. It's thought of as, I don't know what to do. They look okay to me. they're not experiencing these other things. And so I have an idea who has these problems. And so I'm projecting that. So I don't know that my silence is harming people, even though I took a vow to do no harm. So I like the accountability piece a lot. Thanks, Alex.
Nancy, I think we have time for one last question, and then we'll close out this portion of the Q&A. If you'd like to take the lead.
Great. So we have another question, and this question is, how do you think clinicians' own substance use and internalized stigma influence the comfort in addressing substance use with their patients or clients? Would you like to start us off, Alexander, and then Gord, please?
Well, that's a good one. And I know there's a couple others in the chat. If people want to stick on, we can maybe write some answers too, because I know we're not going to have time, because I want to make sure some of these get addressed.
We do have an optional Q&A session that follows this formal part of the webinar. So at 1 o'clock, people may have to sign off. That would be 1 o'clock Pacific Standard Time. However, we will have an optional Q&A session so we can continue the dialogue after this. So if you could address the question that she read out, and we'll continue from there. Thank you.
So I actually really like this question because it gets at the heart of how deep the stigma is. There is a reason that you do not hear clinicians talking about either their own substance use or mental health issues. And I mean, I think some of it is internalized. I think some of it is explicit still. We've made it really uncomfortable for a long time. For example, when it came to opioids, even things like opioid agonist treatment, the mainstays of treatment, were not available to nurses and physicians. And in fact, large parts of North America, when it comes to opioids, I would say that healthcare practitioners don't have access to any kind of evidence-based support. And so this is one of the things that I've really liked about the substance use health framework, is that it normalizes this. It normalizes the fact that a lot of folks utilize substances one way or another. It even normalizes the fact that many people will utilize them in ways that aren't good for their health, and allows some of that discussion to take place. Part of the reason the guidance made such a big media splash wasn't because of the shockingness of some of the numbers. It was because, in my opinion, people were craving a reason to have these kinds of conversations more and more in public. And I think we gave them an excuse and a reason to start talking about these pieces. So as long as, you're right, clinicians feel that they can't safely do it, it continues not do this, but have these conversations, it continues the othering that happens of this. Oh, you know what? You can be somebody who used to use alcohol or drugs, or currently uses them in some ways, but don't think about taking on a safety sensitive job. Don't think about taking on this or that. So again, it's not necessarily normalizing problematic use. That's not the goal of what we're trying to do, but it is normalizing use as it happens and discussions about health as it happens. So I think it's a really, really good question. I don't have all the answers for it. I'm wondering if Gord has more, but I think it's a really on the nose question too.
Thank you. I would like to stop this portion of the webinar and to thank our two panelists, Gord and Alexander, and to everyone who has participated in this webinar. For those of you whose questions we did not directly discuss, please feel free to contact us by email. We would welcome the opportunity to continue the dialogue. We wish everybody all the best with their health equity endeavors. And for those of you that do need to sign off, we understand that 1 o'clock was a time for you to sign off. For those of you who wish to stay for some of the optional Q&A with our panelists, we will be responding to Q&A until 1:30 Pacific Standard Time. So feel free to stay on, and we can see see in the next moment how many people will be staying on. So we'll just put things on a pause for a moment or two. And Gord, building on the previous question that was posed by Nancy, I think that we can probably invite your comments related to that as well, please.
Yeah, actually, the first thing that went through my mind was a list of all the other organizations and service providers that have the same issue. I think about police service members. I think about correction service members. I think about everybody who is actually part of what you would consider to be a highly vulnerable population, because we're looking at people actively involved in potentially traumatic experiences, actively involved in access, actively exposed to violence, all the precursors one would expect to set one up for a struggle around substance use, and yet they're perceived as need to be healthy, can't have any issues, can lose your jobs, and in some ways, farther away from services and care than people who are bumping up against the system all the time and getting the wrong services and the wrong care, for sure. So we have that great tragedy going on in this country where people seriously needing extensive complex services don't get them adequately, and people simply needing access to services from places that would be considered a privilege in almost all societies: educated, unionized, well-paid, insured employees, and trusted people in the community struggling with substance use who can't even mention the struggle, let alone consider the depth or extent of that struggle. And so, as I say, people in comfortable chairs can find no comfort, can also find those services. And so then we're asking them, can you be compassionate towards others? So, compassion's a process, and if you experience it, then you tend to want to give it to other people that experience it. But if you haven't experienced it in your life, I'll go back to, we got a little time, so I'm going to expand here. There was a project out here at a hospital out here who was helping people who were having babies who were using substances, and they did some stigma training work, and they all reported that they would treat people differently going forward. But they were asked, would you treat each other differently? They all said, oh, no, because the presumption was that people in the healthcare system could not yet acknowledge that they might have a colleague or themselves who need to be treated differently to reduce stigma. We interviewed some emergency room nurses in the Ottawa region, and they had this great accidental disclosure, and they said, we never say anything bad in front of the clients, we just talk about them in the lunchroom. The belief that in the lunchroom there was nobody with a substance use issue, and that they were indeed talking about others. So as long as that is there, right? And I think Alex's two questions that he put up there twice, it's just like, what are we doing? Who does it, right? That truly is the big question. And I go back to our first slide as capstone. It's like it affects us all. So looking forward to those changes taking place.
Well, you know what? I think he's behind me. That's why I keep looking like that. But that's good. Easy to be like. Sometimes we overcomplicate stuff for ourselves. Like, let's be honest, we overcomplicate stuff. At the end of the day, what we're really talking about is we're talking about parity. We're talking about treating these the same way we would treat physical health issues. And in the same way that a nurse who has a physical ailment may still be able to return to work, but you know what? Probably can't lift a 200-pound patient or move them into a bed, that because a person is struggling or in treatment or receiving help for something, that there are aspects of their job they can and can't do. It seems so obvious when it comes to all of physical health, but so completely distant when it comes to other pieces. And it's kind of the same. So we become afraid to talk about all these different aspects and all these different pieces. And I think that we can talk about, like we're saying, stigma, we can talk about shame, we can talk about all these different things until we start really dealing with this equally as we do with the physical and general health issues. Like that's really the first step of this. If you're a student, if you work at a hospital, different things, look at your policies, look at your workplace policies. How many of them actually articulate specifically what's done? When we did, CCSA had done a number of years ago, a survey of workplace policies. It was like 850 workplace policies. Found less than 8% had any provisions around substance use health issues, period. So it's just the great silence around this. And if we think it's making stuff safer, I can 100% guarantee that what's actually happening is people are coming in, potentially consuming substances in a way that could be harmful because it's not being discussed, and that it's potentially impacting jobs in a much more significant way. So people are less safe, and also people are not getting the help that they need.
Can I add a note of clarity here? I just feel I need to say it out loud again. We're not talking about people not using substances. CAPS at least is saying we're acknowledging people use substances and are mostly going to continue using substances. That's just a fact. We don't have to talk about that anymore. We don't have to decide that that's good or bad. But we do know that people aren't making their own decisions based on knowledge. And so that's not okay, right? But it's not a yes or no decision we're suggesting for people living in this country. It's, would you like to be informed? You know, sort of like when you pick up a bottle of pop and it tells you what could go on with your health. Would you mind having that on your liquor bottle? That's, I know that may sound complex, but I thought it was simple.
Thank you, Alex and Gord. I think I will read out another question that I think is an important one. Someone has written, as a mom who has lost a child to overdose, and as a nurse working with mental health substance use disorder, how do I get physicians and governments to hear our stories and our sadly lived experiences within the systems within which our children were lost? Perhaps, Alex, I could invite you to comment.
Do you want me to start first? So I can tell you about what I could think are some of the things that could help be more effective, that you can nurse these stories in the context of, or place them in the context of, if we improve healthcare for people who use drugs, that, you know, it's going to create less strain on our emergency departments and help our breaking healthcare system, because maybe that might appeal to politicians or something like that. But I think at the end of the day, not to diminish any of what Rhonda's saying, but we kind of need to stop pointing the finger at people who've experienced the harm and saying, why aren't you holding up the country on your shoulders? And I think we as physicians, as healthcare workers, need to start taking much, much more responsibility in terms of amplifying these voices and making sure that they have power and making sure that their voices are being able to be transmitted. So my advice would be to keep telling your story as much as you can. And I'm very sorry that you suffered that loss, but to keep telling that story. And my job is to keep encouraging my colleagues that they need to be listening, and that when those opportunities are there, they need to hold people up. I think that what true partnership with those who've had lived and living experience is evolving, but is very important. And so I think, I know that there's probably a sense of urgency that you need to do more. And I continue to ask you to do something, but my message to anyone who's listening to it today is, I think the people who've suffered harm have done a lot, and I think we need to do our part now too. So I wish I had better advice, but my advice is more towards my colleagues. I don't know if Gord has anything further around that.
All right, yeah, so I think I hear a couple of pieces, and I'm not sure, Rhonda, if I've met you or taught you before, but I'm not sure if you know about some of the groups that are out there that you can join and be with others around. Groups like Mom Stops the Harm, FAR, Families for Addiction Recovery. There's lots of different advocacy groups so that it's not such a single voice, if that's your experience so far. And I think what I hear in your question is, and not so much how they can hear our stories, but how can they get them to act from the information of our stories, right? And so sometimes when we're telling our stories, which are deeply personal, we need to look in terms of the system level of our stories. What is the system story that's here? So that people can realize it's not about this moment, it's about the moments that are coming, and there is something they can do about the moments that are coming. And this recognizes your loss as being real and meaningful, but it also recognizes that there are losses that haven't happened yet, that something can be done about. And this can build engagement and process. And so I like Alex and like everybody, I'm sure on this call, understand to some degree the nature of the loss you experienced. And I think that there you go, right, Rhonda, you're there. So that's the sort of community building activity that can give strength to those advocating, can break the silence. But I also think your own story about working in the system, this is what you do. Recognize that there's no immunity here. There's nobody out there that can say this will not involve anybody I know. There's no place that immunity is granted around these issues. And so it very much speaks to that necessary piece of including everybody in the conversation, particularly those who think they're not involved. Thank you.
Thank you both for your responses. Nancy, would you like to read out the next question, please?
Yes, we have another question for the panelists. And this question asks, given the stat provided by Gord that so few people are asked about substance use by their primary healthcare provider, what advice do you have for healthcare providers in starting the conversation with people about their substance use that uses a substance use health lens? Alex, would you like to start us off from this question, Alexander?
I feel like I'm getting picked on as the one who has to answer the questions first. I think most people who use drugs or alcohol have it somewhere on the top of their mind or some consideration. My advice is frequently to give people the space to talk about what health improvements they want or what they most want, and that these things come out almost always on their own. If somebody, it's not just health improvements that they're looking for. And I know that sometimes even in those contexts, stigma can prevent people from saying more or sharing more. But often if somebody's saying that they would like, for example, to have to take less medication, or even if they start talking about the fact that they're annoyed by how much medication they take, it's an opportunity to talk to them about their substance use and how it might be impacting their hypertension or the different issues or the things that they might need. If they want to be a better or more involved family member, it's an opportunity. But I almost never begin a conversation with any of my patients or clients by asking them or talking to them what they want to do around their substance use. It's about what things they want to see improved in their lives, what changes they would like to see. I think it's really, really important for the clinician. This is where some of the education around the guidance is really important, to know how health is affected by all the different use pictures and to be able to elicit that from their clients and patients. But I think the most helpful thing I've ever had is to create the space for people to talk specifically about what changes and improvements they want to see in their lives, and then to work with them about how they can get there. And sometimes the substance use piece is not in the picture of how they would like to get there. But if they're informed and they know, then maybe there's other ways they can get there. But a lot of the times it's already top of mind. There's not a single person that I have met who smokes who hasn't thought about quitting smoking. And there's not a single person I've met who drinks more than is in that guidance who has not thought, at least, about their interaction between alcohol and their health. That's not something you need to, that's not the light bulb you're going to be turning on in people's brains. But you need to create the space and the environment for them to have those conversations. And you need to remind people that a healthcare setting is an okay setting for them to have that. As was said earlier in the statistics, a lot of the times people don't feel comfortable. They don't think the healthcare environment is the right place to be doing that. They think a non-medical environment is one. And so I think reminding people, sometimes it's about posters, sometimes it's just even the way that you take a history and you screen about people's use. There's opportunities to normalize, there's opportunities to explore, there's opportunities to help people understand it's part of their overall health picture, but ultimately it's about creating space.
I find I like a bit of a bobblehead today, Alex. And so, people's relationship with their substance use. And you need to know that stigma is real and alive and has impacts. And so if I'm in the doctor's office and you come in and I ask you about your substance use, what you're going to hear is I'm asking you, do you have an addiction? And your answer is going to be no, and you're going to start under-reporting the level of your use to make sure I know that you're healthy. That's just what's going to happen. And so it's really just this normalization. And what I've tried to do myself over the years is understand what I've learned and what I didn't know. And sometimes when I share what I learned with people, they tell me what they learned and what they don't know. And so I think if we have a healthcare profession that it begins to learn about these things and talks about their learning and their personal experiences, it sounds to me like about 78% of the primary care people in Canada use substances. And so they're in a great position to be people with lived experience, sharing their learnings with the people that they're helping. And that's a conversation changer. And that's when they go, I used to have 4 or 5 on Friday after working all week, but I've been reading lately, and it turns out I'm just having 2 now. And then this is why, and I'm wondering about your relationship with your substance use, and if you had the same information I had, or would you're interested in it. It's ironic in some ways that if you go down the spectrum and you get to a substance use disorder, that the whole criteria is about the relationship to the substance use and the impact on your relationships with others. It's not about how much you use or what you use. It gets that way around specific substances in terms of healthcare supports, but the heart of it is about the relationship to the substance use. All right. And so when you begin to talk about your relationship with the substance use as a healthcare provider, you invite others to examine their relationship with substances when you talk about your health, right? So I have this little dream someday, I gotta live a while longer, but I wake up here in a few years, I go see the doctor and they go, geez, Gord, you're getting pretty old. How's the body hanging in? And I go, well, it's pretty beat up, but I'm okay, I'm breathing. And then they ask me how my head's still working. And they ask me about my relationships to substances, if I feel comfortable with that. I don't know the answer, right? Everybody knows the answer to themselves. Sometimes you just don't get asked the question. And on whether I decide to disclose that to my primary care person or not, I'll have that answer when I leave the office. right? That's really the beginning of all this stuff, is when we're able to ask ourselves the questions, or hear the questions, and you can avoid other people's answers quite easily, but it's hard to get away from yourself, eh?
Thank you, Gordon, Alexander. I think this will be our last question, and perhaps we're bringing it back to the spectrum about a spectrum of substance use health. The question is, if we're advocating for using a broader term, substance use health, is it reasonable for us to then only consider the physical health risks of alcohol use? So perhaps we'll switch things up and ask for Gord's comments and then Alex's.
So again, I think that's at an informed personal basis for that decision, that one knows that, and one can be very ceremonial around alcohol in terms of, it's 4 o'clock and I go here and I drink that, and then we go our own ways. And there's also places where they have tea ceremonies, and they places where they have, pizza ceremonies. And so whatever that social context is, right? And it's really, that's about an individual experience, right? And so they're not in a position to really give any guidance on that. But there is some evidence around the physical experience that people don't know, and I see sharing that. But I think that's where you get into those personal risk-benefit decisions. I'll go back to the car story. We know if we drive 50 miles an hour, less of us get hurt, less of us get hurt severely, and less of us lose our lives. And yet most of our speed limits are at 60 and are sometimes called 100 kilometers. And most of us drive at 118 because that's where we don't get the ticket. And so, and some of us have our windows down and some have our windows up. So we have this different experience around driving, and some of us don't drive at all because there's, there's no such thing as an environmentally friendly car. And so those are all personal decisions about cost versus benefits. I think we wade into that area, you get into trying to decide for other people, and we're trying to wade into the area of making sure people are in a position to say, that felt really good. It was great to be with my buddies. And I think I might have knocked a minute off of my 95th year, but I'm okay with that. Versus I just increased my risk for cancer by 15% in my 40s. And I think next week I won't bump that up again. Or maybe I will, because, that seems like a long way away. But whatever it is, it'll be informed.
Yeah, I mean, I'd add it. And this is the one thing I don't really like about a webinar is like, I actually think probably a lot of the people around this would have a lot of really astute and interesting things to share. And I kind of feel silly sharing all my viewpoints as if they're so much better than everyone else's. But, I think it's interesting. I'd go even one step further, Caitlin, maybe ask, what is really the role of our health system? What is fair game or not? So maybe it's not just about the physical health, maybe there's other aspects too. Should I be going to my doctor and talking about how much I spend on alcohol and how that might be affecting my life or not? At what point are finances and the other social determinants of health really important aspects in terms of my conversations around health? And again, what are the aspects that are or are not part of these conversations that we should be having? I think that either way, we need opportunities to dissect what are happening around, for example, alcohol use and what is brought by this or that. Let me give you an example. So if you're using alcohol as the big social outlet for you, what is it about that? What is it about the environment? What is it about it? Is it about actually being with your friends, or is it about using the alcohol itself? Sometimes those things are really hard to dissect, again, in an environment where we don't question and think of and actually ask ourselves. So I think some of it too is just creating more spaces for more information. Like Gord said, to be informed in some meaningful way, and then to make your own decisions and make sure that you're fully making those own decisions. We as physicians and as the healthcare system actually have very little power over what people do and choose to do or not do. I think we could be doing a lot more to help people and to be good partners in helping people make healthier decisions, whatever that word health might mean to someone. I also don't know if you're maybe you can tell us in the chat if there's something specific that you're trying to get at. Like, I don't know if you want us to talk more about the mental health impacts or this or that, but if we missed it, you can let us know if we missed the core of your message. But I actually think that physicians and healthcare workers need to be prepared to have much broader conversations, not just about physical health, not just about mental health, not just about substance use health, but yeah, about financial health, about well-being, about people's families, about all the things that contribute to people's overall well-being and health. And the sooner, not just your family physician's office, but any kind of healthcare setting is a place that those conversations can take place, I think the healthier we can likely be.
Thank you very much. Or any closing comments, or Alex? Otherwise, I think that it's time to wrap up. I'll give you the last word, Gord, please.
Gosh. Well, I had Bob, and again, I think it was wonderful to have so many folks with us in a good way. I really appreciated the questions. And I think Alex really hit the note that, this is about a collective. This is about all of us having these conversations and finding the way forward to a better way of living together. And this idea that for me, and this may be a touch on the personal side, for me, compassionate caring for ourselves as a society is a natural way of increasing society's health. And I know it directly impacts my personal health. And so just this idea of caring for each other that's been expressed here today and finding better ways to do that for me is very nurturing, and to be with you all in a good way. And I'm grateful for Elder Roberta's message at the beginning about being together in a good way. And I hope that we've done that and honored that invitation in a good way. Thanks.
I'd like to again thank our two panelists, Gord and Alexander, and thank you to everybody who has joined this webinar. Greatly appreciated, and the dialogue will continue. And with that, we will end. Thank you very much.